After such a lovely musical session, let's start today's conference in a very positive note. For the first scientific session, as a speaker we have Dr. Arjun Baidya, a famous endocrinologist. And to chair the session, I would like to invite Dr. S.K. Somani, one of the founder member of HDS and one of the eminent neurologists, and Dr. Somnath Noshkar, one of the famous young physician of Howrah, Associate Professor of SSK Hospital. Sir, please start.
So the first talk is about diabetic itch. Itching is a very common and less discussed topic in diabetes. Itching is defined as an intense, unpleasant sensation in the skin leading to scratching, and when this persists for more than 6 months, we call it chronic itch. As medical students, we know we used to be taught about 5 causes of so many things, and itching also has 5 categories of diseases: dermatologic, systemic, neurologic, psychosomatic, and when you forget the 5th cause, you can add either idiopathic or mixed conditions. There have been exciting discoveries, and as neuroinflammation is thought to be important in diabetic itch, cytokines, interleukins, and such pro-inflammatory markers are also being probed into to find a solution to diabetic itch. And for this talk, we have our learned speaker, Dr. Arjun Baidya, who will enlighten us about diabetic itch. Dr. Baidya, please.
Thank you. Very good morning. Thank you, Dr. Somani, for your kind introduction. And I got Somani as my senior, one of the senior colleague, and also as a dada during my MD course. And he was doing DM in neurology, and I was doing MD in medicine. And I saw him how he was dedicated in this field of medicine and neurology, and I get inspiration from him. Actually, he was older than me, and I also did my MD little bit late, and he did his DM. So I think he was even older than me at that time. And I also like to thank Dr. Noshkar. Welcome Dr. Noshkar as a chairperson. And first disclosure is, I am not an expert in this field. I am an endocrinologist. This is not my domain. So I also did not know there is an entity, separate entity called diabetic itch. Very true to confess. And I came to know this topic few months back, about 1 month back, when some of the pharmaceutical industry, they gave me this topic to talk on in a CME. And I became astonished that there is a separate topic called diabetic itch. It is a domain of dermatologists. So I will try to give a scratch on this topic only, and rest depends on you. So this is the flow of the presentation. First of all, I will be discussing the causes of pruritus in general, and also causes of pruritus in diabetes. Diabetic itch, one of the causes of pruritus in a first list. Then I will be discussing the diagnosis of psychogenic pruritus. Then I will be discussing the burden of pruritus, the prevalence and impact of pruritus on life. And then I will be discussing pathophysiology of this topic. And lastly, I will be discussing the management, and then I will give take home. So this is a vast list of pruritus, generalized pruritus, without any obvious skin lesion. So we know that many endocrine disorders can present with pruritus, like hypothyroidism because of dryness of skin, and also many other diseases. End organ failure, like CKD patients also can present with pruritus because of uremia, and some hematological disorders like iron metabolism disorders, hereditary hemochromatosis or secondary hemosiderosis can also present with pruritus. And pruritus can be a manifestation of physiology also. in case of elderly and in pregnancy because of pregnancy-induced cholestasis. It could be a manifestation of neuropsychiatric disorder as a component of psychological and emotional disorder. And also it could be a cause of drug-induced itch. And there can be a separate entity called pruritus of unknown origin, that is GPUO. So this is the diagnostic criteria which is given in, published in Journal of Pakistan Medical Association. So there are compulsory criteria and there are some optional criteria. Compulsory criteria should be localized or generalized without any primary skin lesion. And it should persist more than 6 weeks, then it is chronic and there should be absence of somatic causes. And there are some optional criteria.
Recording in progress.
There should be a chronological association of pruritus with some major life events that could have psychological manifestation, and it varies with intensity with stress, and it is more prominent in night, and the predominance symptoms occur during rest and associated with psychological disorder. So obviously psychotropic drugs and psychotherapies helps to manage this disorder. Now coming to the burden of diabetic itch. So to look into the burden of diabetic itch, let us have a look on this article which was published in Biology. They used different questionnaire methodology to get the idea of prevalence. They used a standardized questionnaire like numerical rating scale, 4-item itching questionnaire, and also to assess the psychological impact of it, they used itching QOL, quality of life, and 6-item stigmatization scale, and also hospital anxiety and depression scale. They evaluated dryness in a non-invasive manner with assessment of epidermis moisturization, and neuropathy was assessed using some clinical neuropathy scale. And it was found that the prevalence of this disorder in that particular study was 35.8% in adult patients with type 2 diabetes mellitus. And actually prevalence varies from 18.4 to 35.8%. So there is a vast range of prevalence because of the difference in study populations, because of the difference in age and also gender, because of various factors. So there is a wide range of prevalence. And they also found some association with some of the metabolic factors, like there was a significant positive correlation with higher fasting plasma glucose when it was compared with non-itching populations, and it was significantly higher, there was a significantly higher incidence of neuropathy in those patients who had this itch, and xerosis was also more prevalent. And regarding the impact of diabetic itch on the life, so they found that there is a mild life quality impairment, and that correlated positively with itch intensity. So more was the intensity, more was
recording in progress.
Quality of life. And significantly higher scores was found in both anxiety and depression dimension of DS. So the primary cause of itch is prolonged pure diabetes control and altered glucose and insulin level, and that subsequently leads to skin dryness and neuropathy in long-standing type 2 diabetes mellitus. They also looked into some of the factors which could exacerbate or relieve the itch. So you can find that there are some factors which can both exacerbate or alleviate. Some factors only exacerbate and some factors only alleviate this itch. So say for example, sleep and also warm bath and dry air and cold. These factors influence in both ways, and some factors like sport, stress, tiredness only aggravate, and some factors like diabetic diet, though we know that there is no such diet called diabetic diet only relieves this itch. Now regarding the etiopathogenesis, Shomanida already highlighted the point that neuroinflammation is one of the important pathophysiological mechanism. Nowadays it is thought that diabetic neuropathy actually leads to diabetic itch, and diabetic neuropathy is also a cause of, we know that peripheral diabetic neuropathy is a cause of pain. So it depends on the intensity of the stimulus whether the patient will perceive itch or pain. So diabetic neuropathy, we know, is the most common chronic complications resulting in neuropathic pain and chronic is both. So the precise mechanism of diabetic neuropathy is not known till now, and neuroinflammation, as I have mentioned, that plays a critical role in the pathophysiological mechanism of both pain and chronic itch. And in the process of neuroinflammation, so neural glial cells are involved and the pro-inflammatory mediators are released from glial cells. So neuroinflammation contributes to the sensitization of peripheral system as well as the central nervous system. So sensitization is the most important factor which leads to diabetic itch. So this is some of the terms and definitions related to diabetic itch and pain. So as Shomanida already mentioned, that itch is defined as an uncomfortable cutaneous sensation that initiates the desire to scratch, and when it persists more than 6 weeks or longer, it is called chronic itch. And as I have mentioned, the central sensitization and both peripheral and central sensitization are the key factors which are responsible for diabetic itch. So in case of central sensitization, increase in sensitivity of the neurons in the central pain or itch pathway leads to a normal or sub-threshold afferent inputs. So when peripheral injury or inflammation occurs, so persistent stimulation of nociceptor or proreceptor leads to increased excitability of the central pathway or decrease in the activity of inhibitory pathway. So there is either the increased excitability or decreased inhibitory pathways function. So that leads to central sensitization when there is persistent stimulus. In case of peripheral sensitization, the nociceptor or proreceptor receptors in the peripheral nervous system have an increase in responsiveness or a decrease in threshold to the stimulus in their receptors of the receptive field, that is the cutaneous receptor. So this is very nicely depicted in this picture, the pathophysiology. This is from Frontier of Pharmacology. And in that paper, the investigator, they actually investigated the pathophysiology in diabetic mouse model. On the left side of the panel, you can see on the left side of the panel, in streptozocin-induced type 1 diabetes, type 1 mouse model, the MGO, methyl glyoxal, which is a reactive metabolites which is found which is elevated in diabetic patients, that was elevated MGO, and that stimulates the ion channels like TRAP1 and NAF1.7 in primary afferent neural pathways. So that causes the phosphorylation of the ERK pathways in the dorsal root ganglion. So that leads to mechanical itch. And on the right side of the panel, you can see in type 2 diabetes mouse model also, similarly P2Y12, that is a chemoreceptor for ADP, adenosine phosphate. We use adenosine phosphate inhibitor as an antiplatelet like clopidogrel. So this P2Y12 is upregulated in type 2 diabetes patients. That activates SGC, that is stellate ganglion cells in the dorsal root ganglion. That leads to pro-inflammatory factor release like interleukin 1 beta and interleukin 18, and that causes reactive oxygen species elevations that actually activates the inflammatory pathways like NLRP3 inflammasome. This is a mediator of inflammation, which causes the activation of caspase 1 from pro-caspase 1 to caspase 1, which actually again activates the pro-inflammatory cytokines to the inflammatory cytokines like pro-interleukin 1b and pro-interleukin 18 to interleukin 1 beta and interleukin 18 respectively. So that ultimately causes peripheral nerve damage and chronic stimulations leading to a spontaneous itch in type 2 diabetes mouse model. So now the important thing is that there is an interconnection, the cross link between the dorsal root ganglion neuron and spinal neuron in the itch and pain pathways. So you can see the neural pathway for pain is highlighted with blue color and the itch pathway is highlighted with red color, and the bold line actually indicates the activated pathways. When proreceptive dorsal root ganglion neurons are selectively activated by either proreceptive or nociceptive stimuli, that is itch happened. But when nociceptive stimuli activate both the proreceptive or nociceptive dorsal root ganglion, the itch sensation is suppressed by the inhibitory spinal neurons and only the pain sensation is produced. So there is a crosstalk between the itch and pain pathway in the dorsal root ganglion and spinal neurons. So pro-inflammatory mediators which are involved in itch and pain are similar, only the cells are different. The predominant cells that contribute to pruritus are the lymphocytes, and pain is regulated mainly by the macrophages and dendritic cells. And same ion channels, I have mentioned 2 ion channels that are involved in both pathways, and different theories are proposed for pain and itch interconnection. And one theory is intensity theory, which suggests that neurons would discriminate between the 2 stimulus depending upon the intensity of the stimulus. More the stimulus, patient will feel pain, and lesser is the chronic persistent stimulus, patient will feel itch. So another theory suggests that both the sensations require separate population of neurons for whom detection of itch and pain is mutually exclusive. Now coming to the management part. To look into the management part, let us look into this paper which investigated the knowledge, attitude and practice towards pruritus management by our Indian physicians and patients living with diabetes mellitus. That was a quantitative survey. And Indian physicians considered diabetes, environmental factors and stress as the major causes of diabetic itch, and they preferred symptomatic relief only. And there are a large proportion of persons living with diabetes who choose to self-medicate and need adequate counseling and awareness. So this is an area of concern. So you can see the symptoms which is present, which are present at the time of diagnosis were many. But the most common symptom is dry, red, itchy patches on the skin. So that was the maximum incidence was 86%. And regarding the investigations, the physician thought the many investigation process might help to diagnose, but most of the physicians, they thought the complete blood count is enough. 92% physicians, they recommend it. And some other investigations are creatinine level, liver function test, renal function test, and blood eosinophil count and serum immunoglobulin test. Regarding the common comorbid association with diabetes, they found that the metabolic syndrome is the commonest association, 75%, and there are some other common associations like hypertension, renal disorders, obesity, hypothyroidism, neuropathy obviously, hypercholesteremia and many more. So, regarding the different factors that were considered while choosing management, is considered as the most important factors, and 83% of physicians, they thought the age is most important factor, and other important factors are the severity of the pruritus and the comorbid association. Now coming to the management proper. So they divided the medications into 3 different classes: topical, oral and topical plus oral, or topical plus oral and injectable. For topical preparations, they recommend topical emollient or moisturizer, topical corticosteroid or topical calcineurin inhibitor like mycophenolate, mopetil. And for oral preparations, first generation antihistaminic like hydroxyzine, second generation antihistaminic like levocetirizine and flexofenazine, and also montelukast, that mast cell stabilizer. For injectable preparations, antihistamine they recommend, and also they recommend immunosuppression like corticosteroids and other immunosuppressions. Regarding the duration of medications, they recommend for topical preparations, they recommend first line for 4 weeks and the third line for 6 weeks. So they recommend it 4 to 6 weeks, and antihistaminics they also recommend from 2 to 4 weeks. Now, the thing is not always easy, and because of lack of knowledge, sometimes we avoid it. patient, they prompt it, they deliver it, they complain the symptoms, but sometimes we avoid it because of our knowledge. So there are many challenges. Physicians' perspective, the challenges are lack of diagnostic tests for pruritus and high cost of treatment and patient compliance. And challenges faced by the patients are also many: fear of increased symptoms and fear of recurrence of symptoms. Regarding the specialty, who should treat this entity first, and what should be the first action taken? So there are also opinion varies, and the first action when started, experiencing pruritus or itching symptoms, patients most of the time they visit the allopathy doctor, 61% patients, and first specialty first visited the general or the family physician, 57% patients. And currently being treated by the same doctor in case of 64% of cases. So diabetic dermopathy is a separate entity of diabetic skin disorder that deserves a special mention. In a 56-year-old male with long-standing diabetes, patients are not proliferative diabetic retinopathy and diffuse sensory neuropathy in food with loss of protective sensation. And you can see the recommendation of treatment for treating diabetic dermopathy. The dermatologists, they recommend occlusive moisturizer, humectants, physiological ingredients, anti-inflammatory agents, and pro-epitheliation, pro-angiogenesis agents, collagen and elastin promoter, and cosmetic agents as well. I am not going to elaborate. So diabetic dermopathy is a common complication, and we need a comprehensive approach for managing this entity.
Sir, can you wind up a bit early?
I one or two more slides. Okay. And we should also advise good metabolic management and lifestyle modification. So the take home is the causes of pruritus in diabetes are many, but diabetes is a separate entity, and diagnosis of this entity needs certain criteria and also high threshold for diagnosis of this condition. The burden of this entity is very high. It ranges from 18.4 to 38.6% or above that. And pruritus may be a symptom of diabetic neuropathy, and it could be a manifestation of microvascular complications actually. And involvement of a small fiber is related to this entity, but it belongs to different neuronal circuits. There is evidence of crosstalk between the pain sensation pathways and itch pathways, and it impacts health or life in a major way.
Recording in progress.
The quality of life, and it has therapeutic implications as well. So early detection and management of this entity is very much needed, and it needs good glycemic control and also lifestyle modification approach. So with this, I would like to stop here.
Thank you, sir, for nicely elaborating such a topic which is very much associated with diabetes, but seldom discussed in conferences, and it's very much debilitating, discomforting to the patient, so much so that many times patients hide it because of some stigma associated with it, and it also compromises the quality of life of the person. And as we have discussed, there is some dermatological and neurological issues. On top of that, diabetic patients are also more prone to fungal infections, and that may add up to the condition. So, if there is any question from the floor, it's welcome.
Good morning, sir. Thank you for nice elaboration on this topic. I actually have two small questions regarding this. So, as you have correctly depicted that there are two major roles of the diabetic neuropathy and in the diabetic dermopathy. So, how these two issues are related for producing the itch to the patients, number one. And number two is as you have mentioned, that the central sensitization is one of the major positive factors for the diabetic itch. So, is there any option of the desensitization procedure like which are available for the pain physicians at present in the world, like the IV Loxicart, or there is some peripheral desensitization procedure like light touching, repeated light touching procedures. So, are these helpful for the patients with the diabetic itch as well? Because these are the already recognized procedures for the chronic pain patients who are having the diabetic neuropathy and facing the pain problems. So please, your comments, sir.
Regarding the first question, how can you differentiate between diabetic dermopathy and
relation between the diabetic dermopathy and neuropathy, and how they are each other related to contribute for the each of the patients?
So diabetic dermopathy, as I have mentioned, it could be a manifestation of microvascular complications. It could be actually the microvascular complication of skin, microvascular infarct in the skin, so without any itch, and obviously the diabetic would itch, have the manifestation of itching, and it could be a manifestation of diabetic peripheral neuropathy. And to diagnose diabetic peripheral neuropathy, we know that we need to go for clinical examination, we need to do some neurological tests, bedside neurological tests like monofilament test, by BPT test, and this is actually diabetic neuropathy diagnosis is a diagnosis of exclusion. So to confirm the diagnosis, you need to get done many things, including the NCS and etc. Sometimes may be needed. But without any other obvious causation or etiological factors, we should think of diabetic neuropathy unless and until it is proved otherwise in a patient of prolonged diabetes patient. So to diagnose diabetic neuropathy, you should go for clinical examination and some simple bedside test. And to diagnose diabetic dermopathy, I think the dermatologists are here. They could highlight the points regarding the diagnosis. Both could be the manifestation of microvascular complications. So we know diabetic neuropathy is a manifestation of microvascular complications, and also diabetic dermopathy could be a manifestation of microvascular complications. Okay. And regarding the second question, so can we use desensitization methods to alleviate symptoms in diabetes? I could not find any paper till now. There is no such study. They investigated some of the medicine like alpha lipoic acid. They used this intraperitoneally, and it was found that it could be helpful.
One more question, please. Have you completed, Dr. Ghosh? Okay. One more question, please. In our day-to-day practice in diabetic itching or the tingling sensation or something like that, along with the drugs prescribed by your papers. Sometimes that is nagging. No, they do not respond to any sort of drug, and we take resort to some sort. Sometimes we do use pregabalin along with the amitriptyline and something like that. Do there is any contraindication that gives some result? A dose of pregabalin and a dose of amitriptyline for intractable itches. That patient says that I'm doing fine, and should I use those things or not? I want to know.
Very good question. So, anxiety and depression could be a component of psychological component of diabetic itch, and it could be also the effect of diabetic itch. So, it is very true that you can use antidepressant or amitriptyline as a treatment modality. So if there is no contraindications, like in elderly male patients, if there is no prostatism, if there is no cardiac disorder, cardiac arrhythmias, or there is no glaucoma, you can definitely use amitriptyline to relieve the itch, because it helps in reducing the depression symptoms. That could be an effect of diabetic itch, that could be a manifestation of diabetic itch as well.
Thank you. As we are running late, I will now close the session so that the next session can begin.
Thank you so much, Speaker. Thank you, Chairperson. The speaker has, the session has been sponsored by Microlabs Limited. Let's have a small slice here by the company.
Thanks for the Chairperson, sir.
Thank you so much, sir.